This is an overview of an article entitled Characterization of Statin Low-Density Lipoprotein Cholesterol Dose Response Utilizing Electronic Health Records in a Large Population-Based Cohort, published in the September 2018 issue of Circulation, Genomic and Precision Medicine. Statin drugs reduce the morbidity and mortality from atherosclerotic cardiovascular disease, or ASCVD, by lowering low-density lipoprotein cholesterol, or LDL-C. For every statin-induced lowering of LDL-C by 10 mg per deciliter, the risk of major ASCVD events is reduced by 5% to 6%. However, individual LDL-C response to statin therapy can vary substantially. While clinical and demographic predictors of LDL-C response have been identified, genetic markers of LDL-C response to statins have not been fully elucidated. Electronic health records, or EHR, linked to biobank data have become an important source of real-world data for the discovery of novel genomic markers for disease and drug response phenotypes. In the paper under discussion, the authors sought to leverage the EHR to, first, characterize statin LDL-C dose response in a multi-ethnic population of real-world statin users, and second, to estimate heritability of statin LDL-C response as the proportion of phenotypic variation explained by the genome. Participants in the study were selected from the Genetic Epidemiology Research on Adult Health and Aging cohort and were members of the Kaiser Permanente Medical Care Plan in Northern California, an integrated healthcare delivery system for over 4.1 million patients. A total of 33,139 new statin users between the ages of 18 and 90 years, with lipid measurements recorded in the EHR from 1996 to 2013, were included in the current analysis. The majority of participants were initiated on lovastatin or simvastatin therapy. To account for differences in potency among statin types, the authors generated a defined daily dose, or DDD, value for each statin type, such that 1.0 DDD was equal to 40 mg of lovastatin daily. The graph on the left shows the statin dose response. A significant log linear dose response was observed in the full cohort after adjusting for pre-specified covariates. The graph on the right shows the statin dose response by statin type. A significant log linear dose response was observed in initiators of lovastatin, simvastatin, atorvastatin, and pravastatin after adjusting for pre-specified covariates. Multiple covariates were associated with LDL-C response to statin therapy. Statin type was a strong predictor of response independent of dose, or DDD, and other covariates. Simvastatin users had a greater percent reduction in LDL-C response to statin therapy for the same DDD compared to reference lovastatin users, while pravastatin users had an attenuated LDL-C response to statin therapy compared to reference lovastatin users. In contrast, atorvastatin users did not have a significantly different response for the same DDD compared to lovastatin users after adjusting for covariates. Women had a greater statin LDL-C response than men after correction for confounding variables. Age was also found to be a significant predictor of statin LDL-C response. East Asians had a greater percent reduction in LDL-C response to statin therapy compared to reference white European participants. Smoking and diabetes were each significantly associated with attenuated LDL-C response to statins. Finally, neither hypertension nor body mass index were significant predictors of statin LDL-C response in multivariate analyses. Overall, 13% of the total variance was explained by dose and the pre-specified covariates added to the model. Statin dose and type were the strongest contributors, greater than 12%. Among the 33,139 statin users, 1,036 individuals had at least one first-degree relative who was also a statin user, allowing the authors to determine heritability for LDL-C response to statins. In 229 parent-offspring pairs, the correlation of statin LDL-C response was 0.060. In 296 sibling pairs, the correlation was 0.054. The heritability estimate derived from all first-degree relatives was 0.117, which was not statistically significant. The authors also examined statin-induced changes in triglycerides, high-density lipoprotein cholesterol, and non-high-density lipoprotein cholesterol. Statin therapy resulted in a median triglyceride response of -14.3% and demonstrated a significant log-linear association with statin DDD. Specifically, increasing statin dose was correlated with enhanced triglyceride lowering. HDL-C response to statins showed an overall median response of 0% and an overall mean response of plus 1.4%. However, increasing statin DDD was inversely associated with HDL-C elevation after adjusting for potential confounding variables. Statin therapy was associated with a median overall non-HDL-C change of -30.6%. Furthermore, a significant statin dose response was observed for non-HDL-C after correcting for confounders. What are the clinical implications of this study? First, EHR data can be used to characterize statin response phenotypes. A significant log-linear dose response was observed in more than 30,000 real-world patients. Consistent with previous literature, LDL-C was lowered by an additional 6% for every doubling of the statin dose. Second, clinical and demographic variables such as statin dose and type, age, sex, race, smoking status, and presence of diabetes were significant predictors of LDL-C response to statin therapy, but only explained 13% of the total variance. Finally, the heritability of statin dose response was estimated at 12%, an estimate much lower than previously reported.